Good evening, everyone, and welcome to Holistic Motion Exercise Physiology. My name is Lewis, and I'll be presenting to you our case study about Max, what his pathology is, and how we will help him achieve his goals. Max is a 55-year-old plumber who had a previous history of a right knee arthroscopy due to a medial meniscus injury from football 30 years ago, which was unsuccessful as he still experiences pain post-surgery. He continued to experience chronic knee pain and was recently diagnosed with bilateral knee osteoarthritis by his GP. He also has a history of bilateral shin splints, which flares up when running. Due to the pain and reduced function from his previous injury and conditions, it has compromised his ability to perform work tasks, in particular squatting past 90 degrees with load, performing knee rotations for golf, prolonged walking during golf, and the occasional jog due to shin pain. The client's goal is to be able to work, play golf, and occasionally jog without knee or shin pain. Based on the data provided, it is evidence that it was an unsuccessful arthroscopy as Max still returned a positive McMurray's test result. We can hypothesize that the knee OA is a secondary pathology to the meniscus injury, as Jindal 2021 stated that previous injury or being overweight can trigger the early onset of OA. As Bennell 2011 stated, OA is a degenerative condition of the articular cartilage which causes bone-on-bone contact, resulting in joint pain and stiffness. This is confirmed by the deficits in strength and range of motion across the lower right limb. Furthermore, these deficits have led to Max to become less active, which could be a contributing factor to his medial tibial stress syndrome due to the occasional jogging pattern, which can be a sudden excessive increase in training load or by doing too much too fast, as mentioned by Galbraith 2009. The other hypothesis is due to the reduced range of motion with his hip extension, knee extension and flexion, and ankle dorsiflexion, which would impact his gait pattern. This is evidenced by the bilateral foot pronation during his single leg squat technique test, which is a mechanism for medial tibial stress syndrome as it places more stress on the tibia. Therefore, we can see how these deficits in range of motion, strength, function, and symptoms of pain can affect the physical requirements of Max's work and leisure activities. This reinforces the importance of having an intervention to help improve his function to return to his daily tasks with an improved quality of life. The goal of our intervention is to reduce pain, strengthen the surrounding musculature of the knee, improve ankle, knee, and hip range of motion and function to get the client back to performing his occupational and recreational activities. Although we cannot improve OA, we can work towards preservation of the surrounding structures for longevity. The intervention will be broken up into 3 phases: short, medium, and long term, which will last 2 to 4 weeks each. The goals of his short phase is to reduce pain with squatting to 90 degrees to improve his ability to keep up with the demands of work. Increase his knee range of motion to 0 to 135 degrees bilaterally, as this will contribute to greater efficiency in biomechanics when he returns to jogging. And lastly, improve his single leg sit to stand score to strengthen the musculature around his knee and improve unilateral strength and symmetry for his return to jogging and golf. The goal of the medium phase is to build upon the exit criteria of the short phase with the addition of low impact cardio. Ideally, the anti-gravity treadmill to prepare him for his return to jogging and increase his ankle dorsiflexion range to 10 degrees or more, as this will allow greater gait pattern and reduce toe drag while running or walking. The goal of the long phase is to improve overall lower limb strength and achieve the client's goals and be able to return to work, golf, and jogging without pain, or at least pain below a 2 out of 10 on the VAS scale. As OA is a degenerative condition, the overarching goal of the exercise intervention for patients with OA is pain management and function. And for this to be effective, Bennell 2011 stated that a combination of strength, aerobic, and aquatic training is recommended. Bennell 2014 also stated that an exercise intervention for OA can have analgesic effects, but with less side effects than oral non-steroidal anti-inflammatory drugs. The priority of the initial short phase is to reduce knee pain when squatting to 90 degrees, improve unilateral strength with the single leg sit to stand, and increase knee range of motion to 0 to 135 degrees bilaterally to progress Max back to his occupational and recreational tasks. Max's exercise intervention adopts some guidelines from the GLAD program for hip and knee OA, starting with a 2-day-a-week program, but with an additional day of aqua aerobics, as stated by Mo 2023, improves aerobic capacity, muscular strength with reduced load on the joints. It encompasses core stability, postural function, postural orientation, lower extremity muscle strength, and functional exercises. The program is based predominantly around circuit training, with day A focusing on quad dominant and day B on posterior chain dominant movements for the lower extremities, which, as mentioned by Bennell 2011, strengthening quadriceps, hip abductors, extensors, hamstrings, and gastrocnemius is effective with OA management. Both sessions start with an isometric exercise of the knee or hip, A1, as Yang 2025 stated that isometrics are just as effective as isotonic exercises at improving muscular strength, but with reduced pain for people with OA. The goal here is to progress Max closer to 90-degree squat with less or no pain by gradually increasing his range of motion with the isometric exercises. Exercises B1 in each program are functional unilateral movements to replicate Max's ADLs and reduce limb asymmetries. These exercises have also been chosen as a result from Van Rossman's 2018 research, which showed there is less shear loading on the knee and tibia, but allows sufficient stimulation on the quadriceps and hamstrings to improve strength. Exercise C1 in both programs are uni-jointed movements that strengthen the musculature above the knee joint by improving joint stability, joint function, shock absorption, and muscle imbalances, which can assist with joint loading and improve gait patterns for Max. Leg extension and leg curls can also improve knee range of motion, as stated by Burnell 2011. Exercises D1 in both programs help OA and shin splints by strengthening the structures below the knee joint, which can improve gait pattern by reducing pronation of the foot, which is a contributing mechanism to medial tibial stress syndrome according to Galbraith 2009, and force absorption to reduce the load on the tibia while walking or jogging. Both the calf raise and tibialis anterior raise exercises can improve ankle range of motion, which can also improve running efficiency and reduce the chances of toe drag, as Max currently only has 5 degrees of dorsiflexion, but at least 10 degrees is needed, otherwise other structures will need to compensate for this deficit. Exercises A2 and B2 are focused on maintaining function and strength of the unaffected upper limbs and to balance the program out to encompass the full body. The exercises are split into horizontal push and pull, followed by vertical push and pull. Strength and function from these exercises can be transferred to Max's ADLs. Exercises D2 are to target core strength, in particular flexion and anti-rotation of the trunk. These exercises have been implemented to assist with the demands of Max's work and build a base for his return to golf and jogging. The powerlift press will eventually be progressed to a wood chop to replicate the golf swing. The stationary bike and ski erg warm-up and cool-down has been implemented as they are low impact on the knee joint, improve synovial fluid circulation, increase blood flow, and muscle temperature to prepare for the session. The reps and sets prescribed here are recommended by the GLAD program as a base to build upon. Progressions and regressions for the exercises in this phase are based around increasing or decreasing duration, joint angle to manage knee pain, joint stability with the use of resistance training machines, intensity by altering workloads or lever lengths, and static to dynamic movements. Lastly, given Max has achieved his exit criteria from phase 1 of scoring below 3 out of 10 for his knee pain with a 90-degree squat, increased knee range of motion to 0 to 135 degrees bilaterally, increased his 30-second single leg sit to stand score to 18 or above, and improved his limb strength and function symmetry to 80%. The next phase will progress on building upon this exit criteria and move Max closer to his goal of working, playing golf, and jogging without pain. In phase 2, the aerobic component will incorporate low-impact aerobic training that will mimic or replicate the end goal of jogging. This could be achieved with the use of anti-gravity treadmill. Aerobic capacity will still be of high priority to not only maintain good cardiovascular health, but also to ease Max's transition back into jogging. Strength training will have less unilateral exercises and start to transition to more bilateral movements for the lower limb as Max has improved limb symmetry. This could look like a double leg press or goblet squat. Hip and ankle range of motion would be the next focus to help improve Max's improvement in gait pattern for more efficient jogging in future. Functional movements will be incorporated into his program to replicate the end goal, but in a controlled environment. This could include exercises such as the wood chop to build strength and power for the golf swing, and deadlifts or Zercher squats to replicate picking up loads for work. Lastly, other variables that would be used to progress Max in his next phase would be training volume, intensity, and frequency through the altering of reps, sets, tempo, load, and training days. Throughout this, we will still be implementing the VAS scale and aiming to manage his score below a 3 out of 10 and the COOS questionnaire to track and monitor his quality of life. Thank you for listening.